Think about where babies are born today. A hospital room, monitors tracking every heartbeat, a team of trained doctors and nurses, sterile equipment, pain medication available within minutes, emergency surgery down the hall if anything goes wrong, the entire weight of modern medicine standing between a mother and danger. Now strip all of that away. No hospital, no doctor, no sterile tools, no medication, no emergency option. Just a woman, a group of people who loved her, and the oldest biological process your species has ever performed. How did any of them survive? And more surprisingly, how did they survive at rates that still quietly astonish the researchers who study them? The easy assumption is that they mostly didn't. That childbirth in the ancient world was a near-certain death sentence, that the infant mortality rate was so catastrophic that having children at all was essentially a gamble with terrible odds. That assumption is partly right about the numbers, but it completely misses the sophistication of what ancient humans actually built to manage those numbers. So let's go back and start with what was actually happening. Human childbirth is uniquely difficult among primates. Every other great ape gives birth relatively quickly and without much complication. The mother often delivers alone. The infant arrives head first, facing upward, and the mother can reach down to guide it out. Human birth is different. Fundamentally, mechanically different. The human infant skull is enormous relative to the birth canal, a direct consequence of the massive brain that makes us human. And the infant must rotate during delivery, arriving face down rather than face up. This means the mother cannot easily reach down to guide the baby out. She needs help. This isn't a modern medical discovery. It is an ancient biological reality that shaped the entire social structure of human birth, going back hundreds of thousands of years. The anthropologist Wenda Trevathan spent decades studying the evolution of human birth and arrived at a conclusion that reframes everything. She argues that human birth became a social event, not a solitary one. Not because of cultural preference, but because of anatomy. The rotation of the infant during delivery means that an unassisted mother is genuinely at risk of pulling against the natural curve of the delivery, potentially injuring the infant's spine or neck. Having a skilled attendant present wasn't a luxury. It was an adaptation. The social nature of human birth, the gathering of experienced women around a laboring mother, may be one of the oldest continuous human behaviors in existence. Older than language, older than fire-making tools, as old as the skull size that made it necessary. So, who was in that room? Or more accurately, who was in that cave, that shelter, that clearing? Across virtually every hunter-gatherer society ever documented by anthropologists, the pattern is remarkably consistent. Birth was attended by experienced women, older mothers, women who had themselves given birth multiple times and accumulated direct, embodied knowledge of what normal labor looked and sounded and felt like, and critically, what abnormal looked and sounded and felt like. These weren't midwives in the modern professional sense, they were knowledge holders. Women whose entire understanding of birth came from proximity, participation, and repetition across years of attending other women's deliveries. The anthropologist Brigitte Jordan, who studied birth across 4 different cultures in the 1970s and 1980s, coined the phrase authoritative knowledge to describe what these women held. It wasn't written down anywhere. It lived in their hands, their instincts, their pattern recognition built across dozens of attended births. And their toolkit was not nothing. It was specific, purposeful, and surprisingly effective. Plant-based pain management was widespread. Across indigenous cultures on every inhabited continent, ethnobotanical records document plants used specifically during labor. Some to manage pain, some to accelerate contractions, some to slow bleeding after delivery. The anthropologist Mormon Daniel spent years cataloging medicinal plant use across North American indigenous populations and found over 2,000 distinct plant species used for specific medical purposes, including childbirth management. These weren't random experiments. They were the refined product of generations of trial, observation, and accumulated knowledge about what worked and what didn't. Ancient birth attendants arrived at a laboring woman's side carrying real pharmacological knowledge, distilled into plant bundles and preparations that had been tested, refined, and passed down across generations. Positioning mattered too. The upright or squatting birth position, which modern obstetrics has largely rediscovered and now promotes, was standard across most prehistoric and traditional cultures. It is mechanically superior to the recumbent position that became common in hospital births. Gravity assists the process. The pelvis opens more fully. The laboring woman has more agency and control. Ancient birth attendants knew this not through scientific measurement, but through the accumulated observation of what worked across hundreds of attended deliveries. The support wasn't only physical, it was social and psychological too. The laboring woman was not alone with her fear. She was surrounded by women who had been through exactly what she was experiencing. Who could tell her from direct personal knowledge what was normal and what the next stage would feel like? The psychological effect of this is not trivial. The researcher John Kennel spent years studying what he called the doula effect, the measurable impact of continuous emotional and physical support during labor, and found that supported laboring women had significantly shorter labors, lower rates of intervention, and better outcomes for both mother and infant. Ancient birth gatherings weren't just practical. They were providing exactly the kind of continuous support that modern research now identifies as one of the most powerful tools available in labor management. The cord was cut with whatever sharp tool was available, flint, obsidian, shell, and the newborn was cleaned and warmed immediately. Cold was the most immediate danger in many environments, and ancient birth attendants understood this clearly. Skin-to-skin contact between mother and infant was immediate and sustained, not as a conscious bonding practice, but as practical temperature management. The colostrum, the early pre-milk fluid, was given immediately, providing the newborn with its first immune protection. All of this happened through embodied knowledge rather than medical understanding. The outcome was the same. The group didn't disperse after the birth either. In virtually every documented hunter-gatherer society, the period immediately following birth involved sustained communal care. Other women helped with nursing. Food was brought to the mother. She was protected from the physical demands of camp life for days or weeks while she recovered. The infant was passed between arms, kept warm by multiple bodies, watched over by the whole group. This was not sentiment. This was a survival system. A newborn whose mother was exhausted or injured needed the group to survive. A mother who could not immediately return to full activity needed the group to feed her. The social structure of ancient birth extended far beyond the moment of delivery into a sustained recovery and support period that modern postpartum care is only beginning to formally recognize as important. And when things went wrong, because things went wrong. They went catastrophically wrong sometimes. Obstructed labor, hemorrhage, breech presentation, infection. The ancient world had no surgical answer to these emergencies. Women died in childbirth. Infants died. This is true, and it is documented in the skeletal record, in the bones of women whose pelvic injuries tell a story of difficult deliveries, in the small graves that appear in prehistoric archaeological sites around the world. The mortality rate was real. The grief was real. But here is what the skeletal record also shows. Women survived. In large numbers, across hundreds of thousands of years, in environments that would seem, from our modern vantage point, to make survival essentially impossible. They survived because of the knowledge system that surrounded them, because of the experienced women who recognized the signs of a normal labor versus one that was becoming dangerous, because of the plant preparations that managed bleeding, because of the positioning that made delivery mechanically easier, because of the immediate skin-to-skin contact and early feeding that gave the infant its first fighting chance. Every piece of knowledge that modern obstetrics uses. The importance of skilled attendants, the value of upright positioning, the use of plant compounds to manage pain and bleeding, the critical importance of immediate skin-to-skin contact and early feeding was discovered not in a laboratory but in the accumulated experience of ancient women attending each other through the oldest, most dangerous, and most essential thing the species has ever done. Think about where babies are born today. The monitors, the team, the sterile room, the medication. All of it traces back in some foe.